Great. Well, thank you so much for that presentation, Dr. Goldfarb. And we'll transition now to a panel discussion, time for questions both from the committee as well as some questions that I have as well. So certainly I think if we have committee members who have questions, please just use your card 10 to indicate that, and we'll do that. I'll at least start us off with the first one, which applies mainly for Dr. Smith and Dr. Friedman. I believe you both had very nicely captured descriptions about treating conditions where there is an acute pain manifestation and someone is likely to present to an emergency room setting. And the use of opioids in that context has been one of the features that has been studied fairly well. I wanted to have each of you comment, if we could start with Dr. Smith and then go to Dr. Friedman, about some of the opioid prescribing that may happen for these patients once they're done in the emergency room and they're transitioned onto another care environment, in particular perhaps to the home environment. And if that is something that you feel like we have some adequate information about through trials, if that is still an open question, or what your perspective is on that.
The first issue is what to do once the emergency department has decided to discharge a patient rather than admit them for a vaso-occlusive crisis. Often patients who are children will have continuity of care, and the issue is pretty much settled. Analgesics can be given by that practitioner, often who will come to the emergency department and see their own patient. When you get to be an adult, you lose your insurance, you lose the continuity of care of a pediatrician. Adult doctors don't want to take care of you. And when you come to the emergency department and are seen, you're discharged back into the ether, into the Netherlands. And so the emergency department, the physician has to decide whether to prescribe a limited quantity, short-term, of opioids. Often they do. And this is occurring on a repetitive basis so that the patient no longer is opioid naive after some period of doing that and is tolerant. Likely not physically dependent, but because they're tolerant, they require increasing amounts of opioids at every emergency department visit subsequently, and they get labeled as addicted. Those patients then have arguments with the physicians about how much opioid to administer at the initial outset, and if there's no individualized pain plan, you can see the tension building, and this has been written about in the literature. The second question is the patient is discharged and sent to a primary care provider or a sickle cell specialist, what to do there? And I think the answer is still short-term opioid prescription according to symptoms until the pain is abated. And in my practice, a supply of opioids at home to use in case of another acute vaso-occlusive crisis, and mostly not long-term opioid therapy, and mostly not long-acting opioid therapy. The third question is patients with the sickle cell disease who have a background of chronic pain and are coming to the emergency department. And for there, I strongly advocate an individualized pain plan that takes into account the dose of long-acting opioid that they likely are on for their chronic pain, the dose of short-acting opioid that they're likely on for their acute pain episodes at home that are managed at home. Most acute pain episodes are managed at home. 3 out of 4 days of a vaso-occlusive crisis are usually spent at home. Those patients without an individualized pain plan are in deep trouble when they come to the emergency department if the physician does not know them. And they will often be undertreated, rejected, not admitted when they should have been, admitted when they didn't need to be. All of those occur.
Thank you, Dr. Smith. Just to follow up before we transition to our other speaker, you had mentioned that has been characterized in the literature. Is it something where your sense is guidelines exist in terms of suggesting how much opioids to prescribe or how much to consider, or is that something that still has yet to be considered?
I would call it an evidence gap in the sense that there is a time during which patients who are having acute, recurrent, painful episodes may go on to develop chronic, sustained pain. And we haven't defined that epidemiologically yet, phenotypically yet, and we certainly don't have the best therapies for that. So it's a real gap. In my mind, the phenotype definition should precede the trials. They're desperately needed, but to do them in the absence of having well-characterized patients would be a disservice.
And lastly, Dr. Smith, you had mentioned in one of your slides about how if we're thinking about applying the framework to patients who have sickle cell disease, one of the challenges would be for patients who have chronic pain and sickle cell disease. Is that one of the main reasons why you mentioned the phenotypic challenge that we face?
Yes. A third of patients with sickle cell disease have pain every day. Over half of patients with sickle cell disease have pain on over half of their days. And this is speaking of adults, and adults make up 2/3 of all sickle cell patients. So we have this massive untreated block of pain, most of it chronic, in patients with sickle cell disease. And we are focusing on the acute management of sickle cell disease because that's what shows up to the hospital. Most patients suffer in pain at home in silence, without alcohol sometimes, but sometimes with, and sometimes with marijuana.
Thank you so much. Dr. Friedman, would you mind fill us in, and then we'll turn to some of the other committee questions.
So I'm very glad that you raised this issue of the differences between IV and oral opioids and the transition going from one to the other in the emergency department. I think this is often glossed over, and it's important to focus on when we're considering dosing of opioids for each of these indications. And so, to put it in context, what are the risks and benefits of giving IV morphine for, let's say, a kidney stone in the emergency room, to get somebody through the worst of the pain, versus dispensing somebody with a 10-day supply of oxycodone to go home with? And I think these issues are should be treated separately, because I assume, I don't think there's evidence to say one way or the other, but I assume that the risks associated with each of these strategies are different. And so for patients who are getting parenteral opioids for truly excruciating pain and who are not going to continue to get parenteral opioids after they leave the inpatient setting, probably have a different risk of long-term bad outcomes than patients who go home with a bottle full of Percocets that they can take as needed. So I think one needs to be careful not to lump these two, and it would be interesting to see studies on outcomes after getting parenteral opioids in an acute care setting and what happens to those patients, and whether there truly is a bad risk profile for patients who are getting IV opioids for acute severe pain.
Thank you, Dr. Friedman. And just to follow up there, is your sense that also we do or do not have guidelines that really specifically address that question in terms of how much opioid should be prescribed, whether they should be used on discharge?
So I'm sorry, if the question is, do the guidelines discriminate between IV opioids in the emergency room and oral opioids upon discharge? No, for the most part, they do not. And most of the evidence that we see is coming from studies of oral opioids, either in the ED or in the recently discharged ED patients. Actually, as Dr. Goldfarb said, we really don't have very many. We don't have any studies at all that look at IV opioids and the long-term consequences of the IV opioids.
Thank you so much. Kit Delgado, I think, has a question.
I'd like to commend the speakers for their excellent presentations. I'm an emergency physician and at practice in West Philadelphia, and so with an ED with a high burden of sickle cell disease. One of the common scenarios is a patient we've managed their pain with parenteral opioids in the emergency department, have stabilized their pain and do not require admission, but they have exhausted their chronic opioid supply, or are having difficulty engaging with a single prescriber after. And so we are in this common scenario where we have to make a decision about prescribing a short-term opioid course. Yet we don't have any guidance on how we should dose those opioids. It could be related to what they were on previously in terms of, and I think that either we need research or some guide, or be able to comment and provide guidance on, in terms of concrete guidance in terms of number of pills of what type of drug for how many days should that short-term prescription, because there's a lot of practice variation. So I'm hoping Dr. Smith can comment on that, and then I have a follow-up question for Dr. Friedman.
Well, one of the issues you raise is practice variation. Some practice variation is warranted, some is not. It's hard to have phenotyped a patient well enough as an emergency department physician to know if they're opioid naive or opioid tolerant, to know if they're opioid dependent, physically dependent or not, and to know if they're taking their long-acting opioid, if prescribed, the way that they should have been, versus taking their short-acting opioid, which is often common, rather than their long-acting opioid, because it works quicker and you can feel it. And so the emergency department physician is unfairly placed in this position of trying to do what a continuity physician should really be doing. If there were an individualized treatment plan for that patient, it would help you tremendously. I'm a huge fan of individualized treatment plans. If there is not an individualized treatment plan and you're in Philadelphia, I think the best thing you can do is something short-term and say, get thee to a physician that knoweth about sickle cell. And unfortunately, there are not many. And I know Philadelphia well, so I know that there are not many there.
And just a follow-up question for Dr. Friedman, just to go back to Mark's point about guidelines for prescriptions going home from the emergency department. There are some guidelines from the American Academy of Emergency Medicine not to prescribe more than a 3-day supply. As you know, there's over 30 states that have prescribing limits on acute opioid prescriptions. Do you think that there should be condition-specific guidelines for number of pills or morphine milligram equivalents that constitutes like the lowest practical dose, or do you think it should be more general or open to interpretation for coming out of the emergency department?
I mean, I would say in an ideal world, we would have a ton of data on every single condition. And so we would know exactly how many days of opioids low back pain patients need and how many days of opioids kidney stone patients need. But, the world we live in doesn't have that much data. And so I think, we are going to have to make general statements based on the data that we have.
Thank you, Kit. Marjorie?
Thanks so much. This is directed somewhat to Dr. Goldfarb, but I'm curious about what Dr. Smith and Dr. think about. I was struck by the fact that most individuals for acute renal colic in that poster study did not get opioids in the emergency room. However, 70% still went home with a prescription. And I'm wondering about barriers in the implementation of specific clinical practice guidelines that might occur where people may feel comfortable with that acute care, but maybe less hesitant to follow the clinical practice guidelines when it comes to prescribing at the time of discharge.
Yeah, that's a very hard question. Maybe Dr. Delgado also has something to say about that, because what the ER doctors are doing exactly is something that's, I think, less clear to me. I don't think there's much literature from that point of view, and so that the questions about acute how many days. All of that is appropriate, and particularly as I pointed out, when you leave the emergency room, very often it's simply because your pain is better. You haven't necessarily passed the stone. And then the patient goes home, and when they ask me how likely is it that they'll pass a stone, I usually say 80% will pass in 4 weeks. Patients are often intimidated by that 4 weeks. What's that 4 weeks going to be like? If they're taking care of their pain adequately, they're going to school and going to work and going about their business. But obviously there are patients who are having more excruciating discomfort, and those patients are going to wind up with a urological procedure. So I think that's a very hard question.
Thank you. Cardi?
Yes, hi. Thank you so much for your presentation. This question is primarily for Dr. Smith. When I think about sickle cell disease, it seems to be one of the only medical conditions we're considering that spans both the pediatric population as well as disproportionately affects minority populations. And so I guess, in thinking about that, my question is, are there particular, when we think about this framework and developing these clinical guidelines, are there particular considerations where there are gaps that we should be thinking about? Like I could imagine, for example, starting to evaluate this acute pain phenomenon when someone is much younger before it gets to be severe could be important. And then there's also the role of bias and stigma and other such things.
And I'll speak to the second issue first. Clear evidence of prescriber bias, implicit prescriber bias when it comes to using opioids, regardless of the condition, and clear evidence of no inordinate requests for pain substances from minorities versus others. The requests are equal, the supply is not equal. So saying that and educating providers about that, I think, is part of implementation science and helping providers to adhere to the clinical practice guidelines that we have already that are clear about administering opioids acutely in the emergency department and even in the hospital. The second point, which you mentioned, is dealing with the fact that we have a condition that affects minorities, a condition that affects people from the cradle to the grave, and clearly over time, there must be some expected incidents of tolerance, physical dependence, and maybe even neuroplasticity and transformation of acute to chronic pain as this disease progresses. So it's a different disease for adults than it is for pediatrics. And maybe that was the point you're making, or if I missed your point, but I feel like that is, we have a well-prepped pediatric workforce dealing with sickle cell quite well. We have a non-existent adult workforce dealing with all these great patients who have made it through childhood because of great pediatric care and are now in the abyss of adulthood.
All right, we'll come over here. And Steve, you want to start us off?
Yeah, thank you, Mark. I'm Steve Weissman from the Medical College of Wisconsin in Milwaukee. I had a combined question really for Drs. Smith and Friedman that has to do with the important role of neuropathic pain in both sickle cell and in low back pain. There's certainly a lot of evidence, a good portion of which, unfortunately, is still in the animal models of sickle cell that show that there is a significant component of neuropathic pain that explains a lot of the persistent and possibly even acute pain in sickle cell, and certainly in low back pain when pain is radicular. By definition, it's neuropathic. Are there roles for using anti-neuropathic drugs as opioid-sparing agents to try to reduce the burden of opioid exposure in the acute setting for both sickle cell patients and patients with low back pain. And then I'll have one brief follow-up question for Dr. Dr. Smith. Sorry.
Great. If we could start with Dr. Smith and then Dr. Friedman.
There are only a few trials of anti-neuropathic drugs for sickle cell disease. I don't think they were well designed because I don't think the patients were well phenotyped. I'm going back to that. If we don't phenotype the patient and understand what we're treating, how could we expect to get a result that is meaningful? So I don't think the evidence for the few trials that have been done is high quality evidence or proves or disproves your question. Secondly, I believe that preventing pain is far better than treating pain. I fully believe that if we prevent the vaso-occlusive and ischemic consequences early in childhood, as was discussed, we will see this pain vanish, this neuropathic pain vanish. If you transplant a sickle cell patient who is opioid dependent, they are not immediately not opioid dependent. It takes months. But it does eventually get better, and you can eventually wean the opioids, suggesting that that pain, even if neuropathic, is reversible in some sense.
Yeah, that really was my follow-up question, which is the role for disease-modifying drugs, in particular hydroxyurea,
Sure.
In preventing acute pain
Sure.
In patients with sickle cell.
Sure, and I believe that the rash of drugs designed to do disease modification that are in the pipeline, once some of them make the market, will set up a whole new set of trials, and I alluded to that in my chart. Talked about opioid substitution, opioid reduction therapy during the acute setting. You would be set up to do those kinds of trials after those drugs are on the market.
Great. And Dr. Friedman, please.
So, the low back pain model is a little bit different, and so we can't really prevent the acute pain because, it's tough to predict who's going to get it. But what we can do is prevent the transition to chronic pain. And I have seen a bit of work done with a variety of non-traditional analgesics, looking to see if they can somehow decrease the transition to chronic pain. And unfortunately, I haven't seen any positive studies. I haven't seen any studies that are actually, using these agents and also, SSRIs and the like, to see if they can prevent that transition to chronic pain. So far, they have not been able to. There's still there are other studies that are ongoing, and so maybe there something will emerge. But with regard to the treatment of acute pain, it seems like the timing of the efficacy of these medications. I mean, it takes a while for these medications to begin to work, and then theoretically the acute pain will be gone by then. So while appealing, I don't know that that they would work within the time frame we would hope to see for acute pain.
I mean, there is some evidence that some of those anti-neuropathic agents actually work in acute settings. The most poignant, I think, are their use in the perioperative setting, where preoperative administration of a number of those drugs, particularly the gabapentinoids, seem to reduce opioid requirements in the immediate post-op period. And I was just curious whether you're aware of or have any experience with using that model, if you will, even in acute low back pain.
Yeah, so I'm not aware of any data that specifically looks at those medications for acute low back pain.
Thank you very much. Pilar.
I'll just add my thanks for 3 really great presentations. My name's Hillary Cunnins. I'm a general internist and an addiction medicine physician. And my questions are for 2 questions for Dr. Smith again. One is back to your phenotype model. You suggested at the beginning that a minority of folks with sickle cell have discrete, acute painful episodes, vaso-occlusive episodes that one could really consider apart from sort of a backdrop of chronic pain. Do you have a sense of what proportion of patients that is? I think you mentioned a third and a half have daily or frequent chronic pain. What about this other group?
The other 40%.
So 40%.
Yeah, it'd be 45%. 45% of patients have pain on less than half of their days.
And in those patients, do you feel that are, again, reflecting on the charge of this committee, a framework such as that you saw is most applicable?
Yes, I do. Step one of the framework is applicable for that group. Trials are feasible for that group, and trials should be conducted for that group. And that group does deserve attention. In the spirit of prevention, going back to the idea, the younger the better, prevention, an ounce of prevention worth a pound of cure, I would like to see younger patients, and particularly teenagers, who are where the transformation from acute to chronic pain seems to be the steepest in its increase. I'd like to see them be parts of these kinds of trials.
And then, thank you. And then, in a sort of a tangent from this, you describe a situation where best care would include really patient-centered, patient-tailored plan of pain management, and suggested that in your practice, and this certainly reflects my past practice, having patients have opioids at home so they are self-managing and early managing their sort of an emergent pain situation is very different from a lot of the current thinking and guidelines around different painful conditions, where a main goal is to reduce the supply of opioids in medicine cabinets, thereby reducing the possibility of use by other people for whom they're not prescribed, or use other than when really needed in order to reduce opioid exposure and presumably development of an opioid use disorder. So I think that's a really important, I would like to hear you sort of just talk a little bit about why you do or don't think this is different and why it's so important.
Well, you just designed a trial. Clearly, the only study that really addressed this was 1992, and the unfortunate title was Treating Sickle Cell Pain Like Cancer Pain. Nonetheless, the study was published in the Annals of Internal Medicine, got huge press attention, huge backlash from prescribers. They were able to cut utilization of the hospital significantly by prescribing long-acting opioids to a group of patients who came to the hospital repeatedly. Poorly controlled, not well designed, not a randomized controlled trial. Lots of reasons not to let that be make a dictum, but it made a dictum. It influenced practice. The use of long-acting opioids took off in sickle cell disease after that. Maybe that was a bad thing. I was one of the people who started doing that. I'll admit that might have been a bad thing. But at this point, there's a group of patients who probably need some prevention after the crisis, as you discussed, but don't get it. And then they relapse, or maybe their crisis is never resolved and they come back and they get hit again with parenteral opioids. And now you're producing opioid tolerance, and you're producing opioid physical dependence. So it's a paradoxical use of opioids when the home supply of opioids might have prevented reutilization and might prevent tolerance and dependence.
Thank you. Roger.
Thanks. These talks were all excellent. I have a question kind of for Dr. Friedman, but also for the other panelists. And, again, this has to get to the dosing issue, which is a little different from this question of whether to use opioids or not. And at least for, the model for a lot of the acute pain dosing guidelines have really been the surgical model, where you have a discrete event and, there's some predictability of how severe the pain is. It seems to me that for these non-surgical conditions that there's so much more variability in presentation, when somebody presents, how severe the pain is, et cetera. And is there, I guess I'm wondering, first, how do you decide how much to give? Is this, I think pain severity is probably one factor. There may be other things that people think about, but is it feasible to make guidance on initial dosing? And then kind of as a follow-up question, I think for the whole panel, the course also seems quite variable, with a lot of factors that influence how severe the pain is and how long it will last. And I'm wondering if there's kind of maybe a different approach to how the RCT should be conducted here. That maybe it isn't about one dose versus another, which you could design RCTs to do, but it may be kind of this individualized, strategy versus some kind of more standardized approach or some other type of management approach. So just wondering if you can comment first on kind of the initial dosing aspect, and then maybe how to look at, how to decide, how long to treat and what doses to give. And I guess just one point, and this is, I think, maybe most germane to the sickle cell example, but maybe also to the stones. At Dartmouth, they've used the amount of opioids used on the last day of hospitalization as a predictor of how long people need to be prescribed opioids and how much, and whether that model might work, or something to be tested for, say, sickle cell or kidney stones also.
Yeah. Well, I would say we're not very far removed from the days when I would, routinely prescribe 24 to 30 Percocet pills with every prescription. Anybody who's getting a prescription for Percocet would go home with a ton of pills, and that has changed markedly in a lot of settings. In our centers, the median is now down to 10, and a variety of different factors have gone into this. Partly awareness and partly active interventions, either through the EMR and all the physician education that's been done. But with regard to identifying what the optimal dose is, that's a tough question. I mean, if I'm designing a study looking to see if there is any benefit for opioids in a particular indication, I'm really going to try to avoid type 2 error and give them as much opioids as I can to see if there's a benefit. That doesn't help the clinician. That's just looking to see if opioids could possibly play a role. With regard to what doses clinicians should use, there's been a ton of data has accumulated so far. Database analyses looking at the association between increased number of opioids prescribed and opioid use disorder down the road, and it's clear that there's a very tight link between number of opioids prescribed and opioid use disorder. And so I think absent evidence of efficacy, and given this understanding that there's really a direct linkage, I think we have to prescribe as little as possible. And I think, maybe Hillary can comment on this, but I think the New York City guidelines are, is it 3 days? Whatever. Going with a very small amount of opioids clearly is the way to go. while giving patients an option to access care quickly for more if they need.
Great. I'll give the other panelists a chance to respond as well.
Yeah, one other point. It's true that it's very common for patients when they email me or call me having a kidney stone. I've got some Percocet. I have some Vicodin. Everyone's got something. All right. And one of my concerns about doing randomized controlled trials is that all of the stuff that everyone's got at home, including alcohol, of course, medical marijuana, I wonder whether you could do a randomized controlled trial under these circumstances where people have their doses of stuff that has accumulated as a result of their hoarding of their opioids at home. It's kind of a concern because people tell me I'm going traveling next month and I'm really concerned about that stone in my right kidney. I'm taking my Percocet, my Flomax, and some Xanax with me. They've got it. I don't have to prescribe it. And that's a long-term issue, as Dr. Friedman's talked about whether or not the randomized controlled trials would be contaminated by those kinds of that availability.
Hoarding is an issue in all pain conditions because prescribers don't like to prescribe and patients like to be safe and secure. In sickle cell disease, unlike, I think, some of the other more predictable pain conditions, I think it would be possible to have two types of studies. One would be studies of opioid naive, use some definition, or make a definition if you would like. You could use the PMP, you could use survey, but opioid naive versus opioid tolerant patients, and try varying therapies based on that to see what you come up with. And the second type of study is the one you said, where you would have individualized pain plans versus standardized dosing. Both of those types of studies I see is quite possible, and don't see any barriers to doing those in a selected group of patients that have no chronic pain overlap.
Great. We'll give Rosemary our last question, if you'd like.
Thank you. And some of what I'm asking has been addressed. Thank you to all three of you for excellent presentations. I'm Rosemary Palomano. I'm from the University of Pennsylvania. So with opioid minimization strategies becoming more prevalent, we have generations of patients, not necessarily by age, by exposure to healthcare, where they've been exposed to opioid minimization strategies and ones who have not. And in the context of person-centered care, how should we be thinking about, and I think to Roger's point in terms of dosing, but how should we be thinking about in terms of a framework for guideline development and taking into context the different types of exposures and how patients present to us? And I think with sickle cell disease related pain in particular, the pediatric population now, many of them have not been exposed to opioids and are in the adult sector, healthcare sector. We want our recommendations to improve the uptake of evidence-based guidelines. Any thoughts on what we should be thinking about?
I think the first thing is what not to do. I would not make the mistake of putting an MME number anywhere, because I believe that a number promotes not thinking about the things we've been discussing. Is the patient opioid naive or opioid tolerant? How bad is their pain? How long are they likely to be in pain? Will it recur again? And what has been their history? What is their risk for misuse? There are tools that can help you determine risk for misuse. And we're developing those tools even for sickle cell disease so that you could, phenotype a person about are they likely to misuse their opioids. So without that background, I don't think you should have an MME number. But I think you should have an MME number based on all that information that is individualized to that patient, or at minimum, based on opioid naive versus non-opioid naive. I think if you did that one thing, you wouldn't kill as many patients, although you don't kill many patients with sickle cell disease with opioids. Let me just stress that. It's, again, 1/10 probably the rate of migraine or of low back pain. And you wouldn't underdose as many patients.
Thank you.
Great. I know we only have about 1 minute left, but I wanted to see if Dr. Friedman or Dr. Goldfarb had any closing comments they'd like to offer as well, or respond to that question.
You know, and the way urologists phenotype kidney stones is makes this the answer to your question in part is pretty complicated, because urologists look at proximal versus distal stones, large stones versus smaller stones, and so it becomes really difficult to amass. Although kidney stones are common, and therefore one would think that you could easily study them. The subgroups are relevant to the likelihood of stone passage, the likelihood of pain being persistent and going on beyond a few days after an emergency room discharge. So that becomes very complicated to divide patients into subgroups that are probably very different with respect to their risk.
Great. Well, oh, go ahead, Dr. Friedman. Sure.
Yeah, sorry. I'm just going to add, it would be nice if we could predict the perfect amount of opioid for every patient. Unfortunately, I think that science just isn't there. And so I'm actually going to disagree with Dr. Smith and say that I think specific MME guidelines or number of days, I think that actually is very useful, because it allows prescribers to contextualize what they're doing, understand how their practice differs from what other people might be doing.
I want to just take a moment to thank all three of our panelists today, hearing from Dr. Smith, Dr. Friedman, and Dr. Goldfarb, for the time that each of you have taken out of your schedules to present and help educate the committee on the various content and perspectives that you all have. And it's very helpful both from my standpoint in terms of trying to craft guidelines for frameworks, as well as that of the committee, and we're very appreciative of that. So we'd like to extend to you our appreciation and bring the morning session to a brief pause as we take a 15-minute break before we switch gears. So join me in thanking the three panelists.